it now?
I
mean, I left the meeting, joined again.
We got it. We got it.
Oh, great.
Don't touch anything.
Can you see the first slide, sir?
Yes, we can, doctor.
Okay, I'll just move. Can you see the second one now?
Yes, we're good.
The third one now?
Yes.
Okay, I am ready.
Okay. Thank you, everyone. Sorry for the technical problems. Doctor, can I, before you start, may I introduce you?
Yes, sir, please.
So, hyperbole is often used in introductions, but in this case, I can't overemphasize. Someday you will think back and say, that was the most impressive person I ever heard. And I think if we look back 30 years into the future, one of the most influential people of the 21st century will be Dr. Ganapathy, worldwide recognized. And if he doesn't get the Nobel Prize, they should eliminate the Nobel Prize. And I say that with all humility for him. He's just incredible. He is a doctor. He is one of the premier neurosurgeons in the world. He has a PhD. He is the former secretary and past president of the Neurological Society of India, former secretary of the Asia-Australia Neurological Society of Neurological Surgery, professor at a number of universities. He's currently also emeritus professor at a university. He was the first person from South Asia to get a PhD in neuroimaging. He's an inspector for the Board of Examinations. He's served universities in Malaysia, in Edinburgh, Scotland, member of editorial boards in telehealth and neurosurgery. He's the first person in India to be trained on stereotactic radiosurgery. I don't even know what that is. And also in robotic radiosurgery. He is literally the godfather of telemedicine. In 1999, he was talking and experimenting with telemedicine when the rest of the world thought it was impossible. He's trained scholars from Harvard Business School. He's written 550 papers, 16 chapters in books. He's the past president of the Telemedicine Society of India. He's just an amazing person. And most importantly, he has used the tool of telemedicine to make healthcare accessible of the highest quality to people in the most remote parts of India. And what's, for me, also incredibly interesting is that he serves in numerous capacities at Apollo Hospitals, which is one of the 3 or 4 largest hospital systems in the world, and is a for-profit venture. Yet, as you got some glimpses in the film, they have been able to find a way to provide Apollo quality services at the time in 2015. I don't know what the exchange rate is now, but at less than $2 a visit. So also his work in ophthalmology and combating eye disease in India, which has been an endemic problem for decades, has been just astounding. So, Doctor, it is always an honor to be in your presence. I'm so grateful for you. He's been here. He's been here physically. We had a conference in 2015. He was here to join us, and he visited us at the Picker Center again since then. But he's been very generous with his time, and as you probably can figure out, it's late in the evening in India. So, Doctor, sorry to take some of your valuable time, but I'll turn it over to you and just tell you that I will be forever grateful for God letting me know you. So please take it away.
Thank you, sir. It's always a pleasure and a privilege to talk to students of Columbia CIPA, School of International and Public Affairs. In the next 30-40 minutes, I'm going to put you into a time machine and take you with me on a journey which I'm absolutely sure most of you are going to witness. Some of us with white hair, I don't know, but nevertheless, here it goes. Futurology is a pseudoscience where one tries to extrapolate cutting-edge technology of today. And this is what I'm going to do. Many of us are afraid of the future. We cling desperately to the present, not realizing that we have already become the past. Now, I'm going to make a statement today and say that healthcare in 2030 is going to be 90% digital all the way. And believe me, India is going to be in the forefront, and we are not going to be a third world down south and other terms which were used 10, 15 years ago, but we are going to talk of the world trying to achieve India class. India is no longer going to try to achieve world class. It will be the reverse, and I'm going to give you enough data to show that this is what we are planning to do in 10 years from now. Digital health is something holistic, value-driven, data-enabled. That is the most important thing. Evidence-based medicine, safe, connected, and most important, trustworthy. A solution is not a solution unless it is universally available to everyone, every time, everywhere. And this is what digital health is going to do. It is going to democratize the way healthcare is practiced. It is going to bridge the urban-rural health divide, which is a problem not only in India, but in every country in the world. What are the objectives of digital health? Improved provider-caregiver experience, reduce costs, focus on value, and equally important, we are talking of customer delight. We are not talking of customer satisfaction, but we are talking of customer delight. Ultimately, any technology is of use only if it changes, statistically significantly changes, in the case of healthcare, on health outcomes. Enhance patient and health outcomes. This is what digital health is all about. You can use the words M-health, E-health, I-health, U-health, etc. And as you can see in this word cloud, this encompasses many, many things. When I was trained about 48 years ago, medicine was very simple. It was a single physician-patient individualistic encounter. Today, we talk of laboratory systems. We talk of data integration. We talk of computer telephony integration. We talk of electronic commerce, practice management systems, and so on and so forth. Look at digital healthcare ecosystem as a command center, a command and control center, where you're not going to pay importance on diagnosis and treatment. Instead, you're going to look at wellness, keeping people healthy. That is the bottom line in 2030. Doctors are going to get paid. Surgeons are going to get paid, not for every bypass surgery they do, but they are going to get paid for every bypass surgery which they avoid doing. And this is what healthcare is going to be all about. Digital health is going to start even before you are born. When you are inside your mother's womb, the unborn, till after death. Yes, I mean even after death, because today spermatozoa can be stored and used even after the individual is dead. A significant percentage of the population believes in cryogenics, and I understand there are thousands of people in the well-to-do countries, including the United States, who actually want their bodies to be frozen at minus 80 degrees centigrade in the hope that over the next 30 to 40 years, 50 years, the bodies can be restored. So this is the future of healthcare. We are talking of government, patient, doctor, nurse, hospital, diagnostic lab, insurance companies, pharmas, and so on and so forth. No longer are doctors and patients the single players in this huge healthcare ecosystem. Every word is going to be preceded Though originally it was preceded by the letter E, electronic, today it is going to be preceded by the letter M. We are talking of M health. We are talking of mobile health. We are talking of a personal health record being stored in your smartphone. We are talking of electronic medical records, hospital information systems, etc., being available on your smartphone. And as you can see here, remote monitoring, insurance, your entire insurance policy is going to be on your smartphone. And I think it is a matter of justifiable pride that India, the Indian government, the Ministry of Health and Family Welfare have a huge separate division called M Health, and there are several thousand people working in the government to promote what is called M Health. The strategic areas for digital health include citizen portals, planning and monitoring, supply chain management. And I think India exhibited this in the last 2 years. At the height of the pandemic, it was absolutely amazing to see 1,300 million people. There was a 100% penetrance of knowledge about the COVID, and the vaccination was done in an absolutely fantastic way using digital health and computer technology. We had surveillance boards. We had integrated health information platform. COVID war rooms were found in every district. The COVID vaccine portal, I think, has already reached 1 billion entries in that, when you take into account that most people have had 3 vaccinations so far. Drug and vaccine distribution system, blood bank management, you name it, and it is all digital, digital, digital. E-visits, a hospital at home. About 20 years ago, I wrote an article in the national newspaper, The Hindu, about a hospital in your pocket. Today, we are talking of a laboratory in your pocket, a doctor in your pocket. Automated kiosks, we are talking of medical homes and care teams. We are talking of ICU, intensive care unit, being available in your home. A home is converted into a semi-automated intensive care unit. We are talking of home monitoring. Virtualizing healthcare delivery, tomorrow's virtualized hospital network. Actually, it's wrong to call it tomorrow. It's already available today, but we are still in a proof of concept pilot studies. And since this talk is about digital health in 2030, I'll stick out my neck and say 5G, which has just started a month ago in the metros of India, will be available almost for the entire mobile network, including the 630,000 villages of India. In 10 years from now, at least 50% of them will have a 5G network. We are no longer talking of doctors. We are talking of healthcare providers. And why is that? Because a new breed of people in India, physician assistants, nursing assistant, the educated paramedic, the patient himself is taught to understand how to do tests. No longer is he only taking blood pressure. He's also doing his own blood test using POCD, point of care diagnostics. And I foresee that by 2030, most homes, at least the middle class, the upper middle class homes in the metros and the tier 1, tier 2 cities of India, every household, or at least 75% of households, will be able to do most laboratory tests in their own homes. Tracking, leverage, government funding and investments, all this are very, very important. Pharma data requirements, drones are already being used in a few centers in India to supply vaccines, to supply blood, and even to supply drugs. These are all pilot projects, but I believe that in the next few years, this is going to be commonplace. I think this slide was wrongly made. As retail becomes stronger, what will move out to the hospital? If I were to make this slide again, I would make this slide, what will be in the hospital? Ladies and gentlemen, it is only major surgery, trauma, polytrauma, particularly intensive care unit, and severely infected patients who are going to be inside a hospital. Everything is going to move outside a hospital. Outpatient consultation will not be inside brick and mortar hospitals. laboratory investigations, imaging, diagnostics, minor procedures, daycare surgery, minor emergencies. Every one of these are going to be in standalone satellite units. The Apollo hospitals, which today has about 10,500 beds, the board has taken a decision that instead of building 1,000-bedded hospitals in the next 10 years, they are going to have hundreds of satellite units which will be connected through 5G to their main core hospitals. And this is what is going to happen throughout the length and breadth of India. So what will remain in hospitals? Only major surgery and trauma. This is a simple example. We started this just 3 years ago. We call it 24/7. You are welcome to Google 24/7 and you will see 11,000 doctors are enrolled in this program covering 220 subspecialties. It is available 24/7 and within 3 hours, we can get a tumor board organized. We can get a medical oncologist, a surgical oncologist, a radiation oncologist, a subspecialist surgeon, a subspecialist imagologist, you name it, and the particular specialist should be available, all of course virtually. And these tumor board meetings are now available not only for the patient, but these are available for the patient's relatives who may be in the United States or who may be in other countries. Blood health checkup, home care, everything is available today virtually. The Apollo hospitals, like many other large groups in India, are now going back and they are thinking of personalized care. Genomic studies are now available in India at an incredibly low cost. Today, for $150 US, you are able to examine 99% of the human genome. And there are at least 20 laboratories spread across the major cities of India where these tests can be done. And we believe that by 2030, genomic analysis will be a routine part of master health checkup. So we think that personalized care, preventive care, this is going to be the future. And we are talking of augmented intelligence. We are talking of using AI in the marketplace, clinical decision support systems, personalized intervention, data harmonization. All this is going to be a part of the regular healthcare. The Apollo hospitals has always been future ready. And I hear about 2 years ago, the board took a decision that it is time to make it into a digital hospital. So here you can see a strategy has already been developed. We are now calling it the Digital Apollo Group. Compliance, predictiveness, prescriptiveness, and this slide is self-explanatory. We talk about medical devices. We are not talking of IoT. We are talking of IOMT, Internet of Medical Things. Integrated care, that is the bottom line. Integration. The word outpatient, inpatient, diagnostics, pharmacy, insurance, supply chain management, whatever you call it, all these cannot be in silos. They cannot be standalone. They have to be integrated. Only then will the beneficiary get rewarded. And this is entirely how cost visualization, clinical excellence, all this is required. Simultaneously, it is not the hospital alone which has to have become digital. The clinician of tomorrow must have digital in his DNA. He must to start with be an explorer, a player, but later on, very quickly, he must become an influencer and finally a disruptor. This is what the clinician of the future is going to be. Social media has to be used in large words, metrics fulfillment, multi-devices integration, as I told you earlier, personal health record. Now, a doctor or a hospital cannot exist in isolation. Ultimately, it is the patient who is the beneficiary. He is your client, he is your customer, and therefore, simultaneously, we need to start educating the patient about the importance of digital health as compared to the original traditional analog health. And so it has to be need-based. We have already started this. Today, the patient is becoming digital and he does online booking himself. He makes payments himself. He downloads the discharge summary. He downloads the laboratory reports. He fixes the appointment. The role of ward secretaries, which was an absolute hallmark of every hospital, will slowly become less and less, and the patient is going to play an increasing role in the management of his own health care. Quality of life, multi-center consistency. And of course, e-commerce obviously will be a part of any digital health strategy. There will be loyalty programs, care continuum offers, etc., clinical history projections, predisposition highlighting, and so on. I had already mentioned that integration is the key word. So we are talking of a new kind of electronic health record. We are talking of an electronic health record which will be available on terra firma, wherever you are on planet Earth. So long as you have an internet connection, you will be able to access this irrespective of the time, irrespective of the country, irrespective of the language. All these projects have started. Yes, it's going to take time, but then 2030, I think we will be there. Connected healthcare devices. This slide is too complex. It will take several minutes for me to even to discuss the single slide, but you can see how we are already started integrating the home care with the pharmacy, with diagnostics, with various clinics, with hospitals, institutions, and so on. Intensive care, as more and more things get shifted out of a brick and mortar hospital into the patient's home. Intensive care, I foresee, will be 40% of a hospital. If a hospital has 500 beds, believe me, 40% of them will be devoted to intensive care. Yes, you can get ventilators, you can get state-of-the-art equipment, but where are you going to get intensivists? Where are you going to get critical care specialists? We have already started a beginning. The Apollo Hospitals, Hyderabad, we have a large command center where a group of 4 intensivists, very senior experienced intensivists, manage 200 ICU beds across 17 different hospitals. And this was 200 a few months ago. By next year, it's going to become 400. So this is the future where we have a e-ICU. And as per one of the papers which we published recently, more than 10,000 adverse events in smaller towns, intensive care units, were prevented from the command center. You can see on the right-hand side of the slide, e-access command center. Small nursing homes cannot afford to have an intensivist or a full dedicated intensive care unit, but they can have a smaller intensive care unit which will be connected. AI. We are not just talking of AI, machine language, and so on. And I'm delighted to inform all of you that we have 6 clinical AI applications now for the last 1.5 years. And hospitals from Canada, Singapore, Dubai, the Netherlands, Maastricht University from the Netherlands, all of them are collaborating with Apollo. We are in discussions with the NHS UK and also with a couple of hospitals in the United States. And this is totally indigenous, made by our doctors in the Apollo system. And this is now being used. The slide is self-explanatory. We are using it for earlier diagnosis of diabetes, for COVID, and so on. For COVID, I understand 19 million patients used this self-assessment at the height of the pandemic to find out whether they were at increased risk, and so on. Preventive health has been one of the major points in digital health. And we are, as I mentioned earlier, we are now in a position to be able to predict with Caucasian data, with Indian data. Until very recently, it was Western data which was used. Simple things like blood pressure, 120/80, blood sugar is 80 to 120. Every one of this was from the Western data, the Mayo Clinic, the Cleveland Clinic, Johns Hopkins, etc. But for the last couple of years, we have got our own data, and we have shown that what is normal in the United States may not be normal, is not normal for somebody with Indian genes. And I foresee that by 2030, we will become totally independent and everything will be based on solid scientific data of Indians, because today we are able to store all this data, large data, big data, predictive analytics. And again, my hats off to the United States. I don't think any other country would have been able to bring out data like this. The US, they showed as early as 2018, Johns Hopkins in a very phenomenal study showed that the third leading cause of death in the United States was medical errors, what we call iatrogenic, preventable errors. In fact, the 250,000 were documented. The authors felt it could be as high as 440 per year. Now, this fantastic study was possible only because of terrific documentation, and the United States has shown a lead to us. Today, India is following this, and you can see here, we already have an error-free medication ecosystem, an illustration of digital employment. So the drug interaction, drug potentiation, there are so many things. Drugs alone kill thousands of people, and today we are in a position to slowly ensure that the incidence of medical errors leading to death becomes lesser and lesser. I foresee that by 2030, every corporate hospital, corporate office in India will have a smart health kiosk. We have been doing this for the last 2 to 3 years. We have a couple of hundreds now installed in various offices. These are all with some amount of intelligence, semi-automated. The beneficiary can sit on the stool, take his own BP, take his own sugar, answer the questionnaire, etc. And I foresee that people physically visiting a hospital from a workplace is going to become lesser and lesser. We are not talking of working hard. We are talking of working smart. And this is the future. This is what is going to happen. Today, we already have sensors by the thousands. We have RFID attached to our wheelchairs, stretchers, you name it, and everything today it can be tracked 24/7. We are talking of affordability, interoperability, and very soon we are talking of economies of scale. We are not talking of import substitution. We are not talking of make in India. We are talking of make in India for the world. We are talking of exporting. And already the imports, which are very high in healthcare, even 5 years ago, is tremendously coming down. This is how most of the tertiary hospitals in the country are. We have a medication intake tracking. We have drug tracking, all with simple RFIDs. And recently, the government of India has announced that semiconductors and chips, as you know, there's a perennial shortage of chips all over the world. And hopefully, India is going to become a major chip manufacturer in the next couple of years and will be self-sufficient in that. So these slides are self-explanatory. This is what is going to happen. I think I got the wrong slide. Sorry, my mistake. Yeah, okay. This is a pilot project now going on in few of the very bigger hospitals. It is all about Alexa, call the nurse, Google, call the nurse, and things like that. Automation of an incredibly high level where you will be able, with a voice command, you can switch off the light, switch on your AC, TV, nurse notification, patient attender, you name it, and everything will be semi-automated. So simultaneously, this is going on. The metaverse, very recently, last year, the Apollo hospitals in Chennai, where I live, has a 9,000 square feet, one of the largest simulation centers in India, where we use augmented reality, augmented virtual reality, extended reality, and so on and so forth, robotics, etc. And we believe that the metaverse, the use of the metaverse in healthcare is going to be a major area in which people are taught. This is just to show the hype cycle for emerging technology. And we believe that very soon these slopes, the peak of inflated expectations is going to become the plateau of productivity. This is one of the largest medical response center which Apollo has in Hyderabad. And I believe that having shown the way, having set the trend, I always think that the greatest achievement of Apollo Hospital Group is not the 72 hospitals they have, but that they showed that in a so-called developing country like India, a for-profit, a dividend-declaring company listed in the National Stock Exchange could provide excellent healthcare and reduce the number of people going abroad. This is one of our active centers. We have 250 desks here, you can see. And I believe that this is the future of Indian healthcare. I believe that in the next 10 years, there'll be at least 200 to 300 such call centers, which will drastically reduce the footfalls into brick and mortar hospitals. Simultaneously, when I talk of digital health, there can be no digital health by a doctor, by a hospital, by the management, by the government, unless there is behavioral modification. For some strange reason, I mean, I have no science to prove it, but I honestly think that the Indian brain is wired in a different way. How else can you explain a 96-year-old woman learning how to use a smartphone? How else can you explain an 80-year-old person living in a small town very quickly learning how to use a tablet? It's almost impossible, and this is not found in many of the so-called advanced countries. So we are talking of e-patients. We are talking of patients who see themselves as equal partners in healthcare decisions. The E stands not just for electronic, it stands for equipped, enabled, empowered, expert, engaged, and perhaps etc. The e-patient of 2030 is going to ensure that every doctor is on his feet all the time. Gone are the days when I qualified as a neurosurgeon in 1980, I told my patient, hey, look, you got a brain tumor, you need to get operated tomorrow. Chapter closed, story over. Today, the patient is asking me, doctor, why do you say I've got a brain tumor? Why operate? Why not radiate? Why not do this? And he puts me through a grilling examination, which I did not face even when I appeared for my viva voce. So that is the present India. I would like to spend a few minutes on how healthcare is going to be in 7 years from now. Investment of 270, these are all reports from McKinsey, Ernst & Young, and other respected organizations from all over the world. 12 million jobs in new jobs, 12 million new jobs in healthcare. CT scans, MRI, PET CT, probably may be made in India. At the moment, we are importing PET CTs. CTs, of course, we make. MRIs also, we are importing them. 1.3 billion square feet of additional healthcare space is what is prophesied by the pundits as required. The development goals, all of these are going to be achieved. And to me, the most fantastic thing which India is doing is universal digital health coverage. I would forgive somebody if they think that we have all gone mad. If you think you could provide universal digital health coverage to every sixth human on this planet who lives in India, 1,400 million people by 2030. Maybe it is not there by 2030. Maybe it will be 2040. Maybe it will be 2050. But nevertheless, a beginning has already been made, as I will show you in the next couple of slides. Every single district in India will have a medical college. When I graduated, there were only 100 medical colleges in India. Today, there are 560 medical colleges in India. We are going to be the most connected IT-savvy society. And of course, 5G is going to be an integral part. Again, economic projections like this. In the last part, you can see 2030. You can see the average household income is expected to steadily increase, and those living below the poverty line are going to become less and less. This is the mission of the Ayushman Bharat, a Government of India sponsored National Digital Health Mission. We are talking of affordability, accessibility, and so on. An enormous amount of work has been done in the ABDM ecosystem, as you call it. They're not catering only to citizens, they're also catering to healthcare professionals and facilities. A huge project has just started. I have a 14-digit, like I have my Aadhaar card, I have a 14-digit healthcare card. At the moment, about 100 million people have got their health cards. And I think by 2030, at least half of India will be having the equivalent of the Aadhaar card for health card. Every single doctor, every single facility, every single nursing home, CT scan, MRI, ultrasound, X-ray, this is a very ambitious project, are going to be digitally documented. So any citizen of India will within a few seconds know what is available where. We are talking of registries. We are talking of health facility registry. We are talking of drug registry. We are talking of unique codes. What do you call that? The barcode. Barcode in every single drug and strip, where any person who has a doubt, all he needs to do is to take a photograph of the barcode and send it to a 1-800 number. And within seconds, you will know if this is a counterfeit drug or not. Pilot projects, proof of concept validation studies are going on. Registry, every single thing to do with the healthcare system is going to be registered. And of course, telemedicine APIs, lab and drug APIs. I wish I had 2 hours to talk about this, but I do know one has to look at the watch also. And so I just want to convey the point that we are talking of digital registries, health records, health claims. And all this universal health coverage is because of insurance, state government-sponsored insurance. Obviously, there'll be fraud. Obviously, there'll be people wanting to cheat everybody. The government has tried to look into this also, and every one of this is only digital all the way. A couple of months ago, the Apollo Hospitals entered into a partnership with Cisco and Bharti Airtel. Airtel, as you know, I think the 3rd or the 4th largest mobile network operator in the world. We have a couple of ambulances, 5G enabled ambulances, where pre-hospital management can be started, thrombolysis can be initiated. We do an we don't wait for the patient to come to the hospital to do an ECG. The ECG is done at the patient's house. And while he's in the ambulance, we do an ultrasound. We can even take a chest X-ray inside the ambulance. Through 5G, we transmit it, and so on. E-hospitals, government hospitals. That is what is thrilling. It is not a private Apollo hospital, but government hospitals are slowly trying to become paperless. I think it's impossible for a hospital to become paperless, but the very fact that they're even thinking about it shows that in 10 to 15 years, the amount of paper in a hospital will be much less. This is one of my favorite slides. We run for the last 3 years, thanks to the University of Pittsburgh, which gives us about $140,000 a year in the remotest part of Gujarat. In the most tribal areas, we run a telemedicine center for the last 3 years. A couple of months back, and I think this is where innovation comes, Juhad, I think that's what they call it, the Indian brain. You can see these people, they belong to the BPL, below poverty line, the poorest to the poor. They probably earn $1 a day or $2 a day maybe. And these people hired a bullock cart. They paid $2.50 for a round trip, hired a bullock cart, and 10 of them, every one of them have got a medical problem. They came to our telemedicine center and they got the same treatment which somebody who pays $20 or $30 in Madras or Delhi or Bombay gets. The same senior consultant, highly qualified, saw all of them. And thanks to the University of Pittsburgh running this project, the patient does not pay anything. In fact, they get medicines which is supplied. So this is the real India. Now, what is going to happen in 2030? I believe that in 2030, instead of these bullock carts, people will be coming in locally made e-scooters. The big towns in India have already started making electric scooters, which cost, I think, let's say about $150 US. For $150 US, $200 US, you can get this bank loan. You can pay it over a period of a year. And you can see this little girl in a small town showing equivalent of an iPad, which again costs about, let's see, it'll cost about $40. For $40, she is able to get this, and using 5G, which will be available, she is able to educate the masses. So this, ladies and gentlemen, is the India of the future. Now, I belong to the BC era. I'm not talking of before Corona. I'm talking of before computers. I was the last neurosurgeon in this country who was trained before a computer was available in a hospital or a CT scan available. I love technology, obviously. I'm passionate about technology. Otherwise, I wouldn't be here talking to you. But I strongly believe, and with the passage of every year, with access to more and more technology, I'm more and more convinced that technology is a means to achieving an end and not an end in itself. I shudder to think of the day when my children and grandchildren are treated by doctors who only rely on machine learning and artificial intelligence. Today, we need website manner. We are not talking of bedside manner. We are talking of website manner. And I think wiping the tears off a virtual patient, tender loving care, this can be done virtually. And I think a doctor, a healthcare provider's primary goal is to ensure that your beneficiary, your client, customer, I don't like these words at all, but these are the modern words used, is basically your job is to provide him with succor to ensure that you give him tender, loving care. So the ideal healthcare provider in 2030, be it India, be it America, be it Ukraine, be it Russia, the ideal healthcare provider should be a combination of Shushruta. He should have the surgical skills of the Indian surgeon 4,000 years ago who taught surgery to the rest of the world. He must have the compassion of Mother Teresa. He must have the pragmatism of Lord Krishna enunciated in the Bhagavad Gita, one of the world's most well-known management books. He must have the genius of Albert Einstein. He must have the innovativeness of Steve Jobs. For all these 5 personalities to be combined, obviously you need to be a Superman. But to be a Superman, it'll be easier if you have the 10 commandments, thou shalt digitally transform. If Moses were to come back to anywhere on the world in the year 2022, November the 1st, November the 2nd, every single commandment would be prefaced by the statement, thou shalt digitally transform. I cannot think of a world without digital transformation. Looking back, I wonder how I lived the last 72 years without digital transformation. And I think digital transformation is the only way to go about it. I think I will stop. Sorry, I hope I didn't exceed the time. If there are any questions, I would be happy to take them. Thank you, sir.
Hopefully not a once in a lifetime, but maybe. Questions, comments?
I hope the audio video was clear. See, the problem with the virtual lectures, once I went on talking for 40 minutes, not realizing that there was no power at all at the receiving end.
Thank you. I've sat through, I think, thousands of presentations like this at my firm. And this is by far, I think, one of the top 3 I've ever heard. So really, really incredible. I have 2 questions for you. You mentioned the metaverse, and this is one of the spaces that I've been very involved in. I'm curious how you see the timeline of this happening and how the interoperability of these different metaverses are going to allow people to utilize NFTs, haptic touch technology, neural interface device technologies, to actually be usable where that human and technology do wind up merging. You mentioned that it's within the next, let's say, 20, 30 years, but how is that timeline actually going to occur?
If I could answer your question, sir, I need to be a magician, and fools rush in where angels fear to tread in predicting the future, and I certainly am not an angel. Having said that, the future is ahead of schedule. At least in India, in the last 10 years, I have found that what we thought would never happen in our lifetime is happening. And I'm very optimistic that this is going to take place. Most of this is already taking place, but then they're taking place in isolated areas here and there. For it to become a standard of life, for it to become an integral part of the healthcare delivery system, is going to take place incrementally. It's not going to take place all of a sudden. And I think it's going to happen within the next 10 years. I mean, it's impossible to predict, but in the political system, at the end of the day, it's a political will which matters more. I always say that telemedicine took a tremendous progress, not only because of COVID, but also because the government, the state government, federal government, state governments, all realized that the only way to bridge the gap was through technology. So I don't know. I don't know what's going to happen to the political situation of our country, but I'm very optimistic. I'm talking of 10, 15 years, not 50, 60 years.
Thank you. I have one other question. So you mentioned earlier in the presentation about cryogenics. So I'm curious how you feel that the work of Colossal, Kurzweil, Aubrey de Grey, how that is actually going to be to pass this regulatory regime when there are no real free zones and sandboxes outside of Dubai, Abu Dhabi at the ADGM. So how do you foresee that technology being able to be mass commercialized where it's not just going to be extremely expensive as it is now?
I mean, to me, it appears impossible to be able to revive Homo sapiens, to revive a human being. But I think cryogenics is already, there is some data in laboratory animals, in small rats and mice and things like that, etc., that they could be restored. So restoring functionality to small organelles or even organs may be possible in the next 10, 15 years. But if we are talking of storing a human being clinically dead, I think that's just not going to happen.
Thank you, Doctor. We have another question. Two more.
Hi, Dr. Ganapathy. Thank you so much for your presentation. It's truly been an honor to sit through your presentation. My question is focused a little bit on the before COVID era. I was wondering, when you started the whole telemedicine movement in India, did you receive any pushback from healthcare providers? Because healthcare in its very nature is touch and feel. Of course, because in COVID, everything shifted online and we were consulting doctors and healthcare providers online. But would you be able to help me out with an answer here? Thank you.
Fine. Yes, you are right. For millennia, for centuries, it has been a one-to-one relationship, a touch-me relationship. But interestingly, I always felt that the main problem was not that. I mean, I hate to be I've never been a diplomat in my life. I call a spade a spade. Now, for some reason, everybody expects a medical doctor to be the greatest philanthropist of all time. Now, this is just not going to happen. Yes, a doctor may not insist on his pound of flesh for every consultation. He also would like to help society. The biggest problem which we faced in introducing telemedicine was what I coined an acronym called YFM. You must have heard of Wi-Fi, WiMAX. So WIIFM. What is in it for me? So the biggest problem was, how would the medical doctor get compensated for his effort and time 10 years ago, when the patient is 1,000 miles away, 800 miles away, in a small town, in a village, and I'm in a big city? That is where digitization radically changed everything. And this may look stupid, but I will not be shocked if currency notes in India become historic 30 to 40 years from now. It's amazing to see people using less and less of currency note. Everything is digital transaction, GPay, and there are at least a dozen different things. So the biggest problem we had was to collect money from the patient who's 800 miles away and give it to the doctor. Today, that problem is totally solved. So I think that was a major reason why telemedicine picked up in huge way. One. Two, the answer to your question is, I remember my professor telling me the more formal university education you have, the less common sense you have. And I think he's absolutely right. The higher your university education, the less common sense you have. Most of our people who apparently are not formally educated, they are the brightest of the bright. So they realize that instead of traveling 18 hours instead of spending $60 going to a place so that the doctor can touch you. If there is a method, they can see the doctor on a screen, they would any day prefer that. So you are right that given if I have the option of both between physically seeing a patient and virtually seeing a patient, and the both economically, time-wise, everywhere else, it's more or less equal. Even today, as a evangelist in telemedicine, I would still advise physical consultation. If somebody calls me and the guy says, can I come and see you in 10 minutes? I stay across the street. I'll say, yes, please do come. 100% that is what I'll do. But when the person does not have access to a specialist, he understands this, and the less formal education he has, the quicker he understands, the more he accepts it. So behavioral modification, as you call it, is a function of necessity. When something is required, to hell with all the 500 years, so whatever you have, legacy systems are difficult to disinherit, but not when it is a question of absolute, it's necessary.
Two quick ones.
Okay, thank you, Doctor, for your explanation. And I would like to ask you for explanation more about how do you prevent or mitigate the misdiagnosis in the virtual examination, for example, due to the limited visual ability for the doctor to see the patient, or probably because the patient themselves is unable to explain it clearly what they feel, what they which pain they suffer, or for example, like that. And how do you mitigate that for the misdiagnosis and also misuse of the telemedicine? Thank you.
Very good question. Most of the doctors, we train them, even very senior consultants who are highly competent in their professional cutting and stitching, maybe before they embark on telemedicine, we impress upon them the fact that it's always better to be on the safe side. I expect my clinicians to be mature enough to know enough of general medicine, general surgery. Whenever you have the slightest doubt, you are not happy with the history you get, you don't know what really happened, particularly did this patient have a fit or not, the history suggests a fit, but on examination, 99.9% of people who had fits on examination, they do not have anything at all. So I expect my doctor to err on the side of caution. And in the earlier days, about 10% of teleconsultations, we would say, sorry, you have to come physically. I'm not satisfied with the audio quality, the stethoscope, the stethoscope which I applied on you 400 miles away, the heart sounds which are transmitted through a 1 Mbps bandwidth. I'm not happy with the quality of the sounds. I'm not happy with the quality of the video. I'm not able to see your pupil, etc., etc. I cannot take a decision. So I'm calling off the teleconsultation. Please physically come. With increasing technology, etc., this will becoming less and less. But the answer to your question is the doctor has to be mature enough, has to be knowledgeable enough to understand that when technology has failed them. We still do that. Having said all this, maybe I am not able to recollect. Of course, we don't have 100% follow-up, but over the last 22 years, where we have done 13 million teleconsultations, the entire group, I am not aware of any single gross mistake which resulted in the person going to court or legal or criminal charges or legal charges or something. That generally doesn't happen.
Last question.
Hi, thank you so much for this incredible presentation. I was wondering, when you think of precision and personalized medicine, when it comes to preventative use cases, what are the 3 sectors that excite you most?
I'm sorry, I didn't hear you clearly. Could you please repeat it, madam?
No, don't. Oh. Is it green now? On the top. Look on the top.
No.
Sorry, the audio was a little jumbled. I couldn't make it out.
Don't touch anything. This is how I deal with my wife. Don't touch it.
Okay. Hi. Thank you so much for your amazing presentation. When you think of precision and personalized medicine, when it comes to preventative use cases, I was wondering what the 3 areas are that excite you most.
Okay, when we talk of personalized medicine, as I said, we are talking mainly of genomic analysis. So we take a very detailed clinical history. For example, let's say an 18-year-old girl come, his mother had cancer breast, her grandmother also had cancer breast. And then today we can do us with 2 ml of blood, we can identify with a 99.9% precision. So we know that she also has a 99% chance of developing a cancer breast. Like that, there are many, many conditions today. So we customize it like diabetes, rheumatoid arthritis. There are so many conditions. So mainly when we talk of personalized medicine, we are talking of genomic analysis, which luckily is available in India today at a fraction of the cost.
Doctor, you're the best, as always. Thank you so much. I think we've adequately recorded it, so we will send you the link so you can get the recording. And I hope I'll see you soon. But thank you so much.
Thank you so much. Thank you all. Thank you, everybody.
Get some sleep, doctor.
Thank you.